Hello, this is episode 8 for the live Q&A. As always, people will join and ask questions as they need or want to. And I will be going through things that come up from the week. So, first, what we're going to talk about is something that was messaged to me. Um, It was from a parent who was seeing a lactation consultant, and the lactation consultant told the parent to not give bottles because bottles will support the oral motor deficit, or it would counteract anything that they were doing to prevent oral motor deficiency by bottle feeding. So that is hugely incorrect. And I think that is where there's a big disconnect between lactation and bottle feeding community. This mom was super anxious about potentially needing to leave the house because she felt like she couldn't introduce a bottle because it would be detrimental to the baby's oral motor development and everything that they had been working towards. So that is a prime example of why bottle feeding education, how to bottle feed, can really support these parents. And that is the direction that we need to go in. So the lactation consultant, told the parent that bottle feeding doesn't allow the jaw to move forward. And that is exactly why I talk about sideline feeding so much, because that is accurate. When we feed in cradle position, we are putting pressure on the jaw. Gravity is moving downward. The jaw is not moving forward. It is being pushed back. And that is true. But it's not bottle feeding that's the problem. It's because parents are not taught how to bottle feed. They're just given a bottle, and we see this in movies, and this is how we were raised looking at bottle feeding. And so that's what we do. But if you simply move the baby up, if you want baby close to you, or you lay them in sideline, now the jaw is moving forward. Now we're not pushing against the jaw. And that is how we should be feeding. That will allow the jaw to move forward. Then it's not bottle feeding that's causing or disrupting any sort of progress you're making with oral development. The other part was that it impacts the palate, which absolutely can be true. But 20 minutes bottle feeding 6 times a day, I'm more concerned about what the tongue is doing the rest of the day, because that tongue on the palate space is what's really going to make the biggest change. Um, but using a bottle that is sloping versus a narrow shape, or wide, your traditional wide, where the nipple comes down even further and then splays out, this sort of nipple is going to be more beneficial for oral development in terms of keeping that wideness at the base, and not narrowing everything down. And so, again, it's not the bottle feeding that is the problem, it's the lack of education and support for people who use bottles. That's the problem. I was very disturbed by that message. I hope that mom understands that you can bottle feed and breastfeed and work on oral development and have a beautiful mouth. Um, in fact, the argument to that, to push even further, is that baby has a high palate, is struggling with tongue function, and exclusively breastfeeds. So where's the argument for maybe it's not just about how baby feeds? Maybe it has lots to do with what's happening outside of feeding that impacts oral development too. Um, okay, so I wanted to share my thoughts on that so that it's recorded and people can listen to it as much as they need to feel safe with their decisions and get rid of that bottle guilt if you have any. As usual, drop your questions as you need them answered, and I will go through. The other thing that came through that I wanted to talk about, and I really should start writing these down because I'm not remembering. Um, but the posts that were discussed were baby holding the bottle on their own. Oh yeah. So I had some therapists reaching out saying that bilateral upper extremity range of motion, strength, and coordination is assessed around the 6-month age range. And so they do look at bottle holding a bottle as a skill. And let's dive into that because the next statement she said was, although there are other skills to look at, um, if the baby is breastfeeding exclusively. Well, shame on this community because why are bottle feeding parents and babies held to different expectations than breastfeeding parents and babies? If we can look at something else to reach that skill for a breastfeeding baby, we should be doing the same for a bottle feeding baby. And I've talked to physical therapists and occupational therapists before about taking that particular wording, can baby hold their own bottle, out of their assessments. How about we ask, can they hold objects out in front of them? Um, because that's what they would be looking at if it were a breastfeeding baby. The bottle, holding a bottle specifically, is not a developmental milestone. And if parents want to keep that bonding experience for as long as they want, breastfeeding parents can keep it for as long as they want. Bottle feeding parents are already limited to 12-month marker. Even at 10 months, we're starting to eliminate bottles, right? So we're already taking away that experience and that interaction between the two. Um, so why are we wanting to do it earlier and earlier in the name of meeting a milestone when that's not the milestone? The milestone is hold upper extremity coordination and strength, not holding a bottle. So I think that that's really important to talk about and put out there into the world. Um, the last thing that we talked about was oral play. Of course, the original point of my business was to get parents to engage with their babies more, understand the importance of oral play and what that can do for their entire feeding journey. Um, I see my oldest has lots of oral motor issues. And when I'm looking back, and you're always looking back and you see things that you could have done differently, but the thing is, I couldn't have done it differently because I didn't know any different and nobody was telling me any different. And I saw things with him and I was dismissed and dismissed. And he ended up in a helmet. And I pushed that significantly because I was still being dismissed. And so I think that my goal is really for um, health providers to understand the importance. There's a lot of speech therapists, which I am, um, who don't even, if an infant's having feeding difficulties, they don't even know what to do with them. They won't see kids until myofunctional therapists won't even see kids until age 4. That is a long time of oral development that we can make change to. And so the holding tension is not a bad thing, and it's not something that is a novel idea. We as human beings are always holding tension. And so for us to not put that same um, idea onto an infant, they are a human being, and they sleep wrong, they get growth spurts, they are having a bad day, they're going to carry tension in their body. And simply doing some activities to release that tension in the mouth can change their feeding experiences. And so oral play, I will always stand by for every single baby that's born. And my goal is really doulas. And I mean, I don't expect pediatricians to get on board with this. probably forever, but I mean, in the next, 100 years, maybe. Um, because their feeding is not intensive. And I guess I hope that they become more open-minded, and when parents start to have feeding difficulties, it's not okay, just switch a formula. It's not, oh, just give them a bottle and stop breastfeeding. It's not just thicken the milk. Just go to GI so they can be put on medication. There are other ways to support babies' growth and development that don't require them going down this medical track, where we can support the body the way it was made. And so, our health practitioner, our holistic practitioners, I can see coming on board hopefully with this, doulas, especially doulas, because they're there right in the beginning. And the more doulas that can have a good understanding of oral development, and or just simply the importance of incorporating oral play into daily life, would be phenomenal. Um, a therapist, of course. By the time that babies are being referred for therapy, there's already so much of the motor plan that has been developed that, when I'm seeing these babies, I hope to get them before they have this strong established motor plan. And that's not happening yet. When I get the babies, we've stacked, we're already stacked problems on problems. And so oral play, of course, is always part of my plan, but I'm giving them specific ones to do versus just having this guide where you do general oral play to prevent. And so that's what the guide is really for. It's to prevent them from ever getting to me. But I guess that goes against the whole medical ideology of the society we live in, right? Like, their goal is for you to go to the doctor, not to have everything you need to not go to the doctor. Um, so that is the premise behind that post. The more parents understand that that should be incorporated in their daily life, just like tummy time is. And tummy time's been around for a long time, and it's still, people are not understanding the importance, or how to do it. They're still being told to just put baby on their belly and let them scream. That is not that's not correct either, right? And so I think we have a lot of work to do in terms of preventative measures, but that's that's like, will it ever come? Probably not. Um, I mean, it's getting better, because I know that when I was growing up, somebody who did what I did would be so hugely off the wall and a complete quack in everyone's opinion. Um, but I think that my generation is feeling the problems of what was done to us, um, in terms of feeding and just development in general. Um, so many problems with fertility and um, digestive issues. Like, our bodies are not in good states. Me and most of my friends and most of the parents I work with will tell you the same thing, is that we are learning from our development mistakes. And I think that is a good shift in the right direction. But history always repeats itself, right? And so while this is a really good shift into holistic medicine, eventually, um, I will be considered a witch again at some point. Um, so my goal is probably unrealistic, but I'm hoping that I can make a difference in just a tiny piece of the world. Um, okay, so I think that was all the topics I wanted to talk to you guys about today, and no questions. So let me make sure I have all of my pieces. I will leave it at that. And I will see you guys on Thursday. At the same time, there was someone who wanted me to answer questions about their particular situation, but they didn't ever ask me a question. Um, they she mentioned my baby has low muscle tone. I asked her to look at the body, nerve, sensory system, and motor impairment because that is what I push when you're going to see a provider, that they look at the whole body. And she referred them to a physiotherapist. What do I think of that? I think it's great if the physiotherapist is good. A therapist is the amount of people who say, well, I already did speech and OT and cranial and sacral and all the things, and there's no improvement. And then they make an appointment with me and we find that missing piece. Um, Therapists are not created equal, and it's unfortunate. Um, but we don't all do the same training. We don't all problem solve and look at things the same way. Um, which is so unfortunate. But if you don't get the answers you're looking for from someone, it's not that there's not an answer, it's that they weren't the person for you. And that's easy to say when you're not the parent who's spending money and money and money and money. And I get that. Um, it is why I created the guides so that you can have a piece of my work. And implement it at a very cheap cost. Um, but I also like encourage parents to almost go on an interview when they're calling the outpatient clinic. Hey, do you have a therapist that specifically works with infant feeding? Yeah, they do infant feeding. What ages do they specialize in? Can I speak to the therapist first? And ask them, are you comfortable with these issues that my baby's having, or do you know someone in the community that would be able to help better? um and sort of get a feel for them and their vibe. There's plenty of parents who have talked to me and didn't like my vibe and left and went to someone else, which is totally fine. Because if I give you things to do at home, if you don't trust me, then you're not going to do them. And then there's not going to be any progress. So it's not because the activities weren't appropriate, it's because they weren't implemented, because there was a breakdown of trust between therapist and client, right? And so that is really important. Um, and there's plenty of people who do not um, like me. So you can choose that. You can get a feel for them and call around. I'm not sure what tests should be done regarding his muscle tone because his entire body is really weak. Plus, the suck swallow is not effective. You are right that the reflux is not the problem. Something is going on for sure. We have to fight for tests and referrals in Canada. Could you please help? Okay. So, the important piece in that discussion right there is that we're looking at tone. Tone of a muscle is, there's no specific test. Um, it's a range, and a physiotherapist, I would assume, could test that. They may have a specific test that they use, like a physical therapist. I'm guessing you're not in the United States because we would say physical therapist and they're saying physio. um, I'm assuming it's the same thing, but they may have a test. Let's say they give a test to test tone. My thing with tone is that there's a huge range of normal. And you can be normal tone, you can be normal high, and normal low. Your low tone is usually when we're looking at diagnosis of, a good example is a baby with, or a person with Down syndrome. That person has low tone that's outside of normal low tone. Um, and so and then your hyper tone, like your high tone, is going to be people, individuals who have like contractures in their muscles. And so a good example is, a person with cerebral palsy could have higher tone, where the tone in their muscles, um, um, is high. It's the opposite of low. It's high, right? But it's outside of what would be considered a normal tone. Um, because you can live in this normal low tone range, it's like, what do we do for those babies? Because what's important to remember about tone is that you cannot change muscle tone. It is genetic, it's what you're born with. The muscle will stay that way. That is its response to stimuli all the time. What you can to support low tone is increase strength. If you increase strength, it can support that low tone. It doesn't change the muscle's response, but it will make the muscle stronger. Um, and so babies who are low tone, I'm always doing lots of munching. And if you start with munching, you'll find that maybe they almost like don't even munch at all. And then they start to get a little stronger. That's where your chewy tubes come into play, because they start munching on that, and that resistance makes them stronger. So muscle tone can't be corrected, but we can get them stronger. And that is where your therapy is going to come in. What are they going to do to improve the muscle tone if they say that it's low? Um, Sorry, I lost your message. Um, so his entire body is really weak, and so he has, let's say he has global low tone. I don't know, but let's say that they do that, then we're working on on strength activities, positioning to put him in to encourage those muscle building, because those babies are just floppy babies. They're my floppy babies. They're squishy. And so giving them those activities will help build strength to support that low tone. The suck swallow is not being effective because it's requiring these muscles to work. And so when it's low tone, they're a little floppy. They're just going to be a little lackadaisical with their movements. But doing different activities, suck training, depending on age, because remember, suck training can be effective, but I find that it usually is not as effective once their baby's past 6 months of age. Really, between when 4 months hits, we're really losing. 3 to 4 months is when they start to lose that suck reflex, right? And so, if we're 6 months and we're still munching and not engaging with a suck reflex at all, I usually find that that is not something that I work on. But munching is good to work on these muscles in here for jaw support. You can do different tongue activities, but I find too that if your muscles are floppy and they're not moving like we want them to, they sit low, then we do carry tension. And so that is something to look at, because a tense muscle, once you release that tension, is weak. Tense muscle is a weak muscle. And so that is something that they can give you to look at and work on. Um, you're seeing the physiotherapist, so you're moving in the right direction in terms of referral. Let's see what they tell you, and and we build from there. um but as far as a specific test, if baby's showing all signs of reflux, then he has reflux. If you're struggling with low tone and latch, and feeding's a hot mess, then we know baby's intaking lots of air. That needs to be looked at and corrected. So what can you do for that is what I would want that physiotherapist to look at. Look at feeding, and how can we improve feeding to decrease air intake to then support that decrease in reflux. I hope that that helps. Okay. Okay. Last thing is wanting more information on supporting children with a high palate. Um, I'm just going to read it to you. My son has a high palate. He had 2 tongue tie clips. The first was a disaster, and as an older baby, he has gone through oral trauma. I fear until he is old enough to understand, we won't be able to get into his mouth successfully to support his oral well being. So, in the oral play guide, there is a section for babies who are sensitive and how to integrate touch, reaching up to the mouth finally and into the mouth to improve that whole dynamic, because we want baby to have a good, positive relationship with oral experiences, and oral trauma is a real thing. And so I do want you to continue to try to engage with him in a very pleasant, non like dominant way. We are going slow and easing ourselves in. Hold on. Evan, thank you. So that part is something else. Like we need to work on that in order to get that oral acceptance. Um, the the high palate issue, the tongue helps form the palate. Okay. If he won't let you in the mouth to release tension and or practice clicking or do anything or stimulate palate awareness to get the tongue up there, the next best thing is the guppy stretch. So work on the guppy stretch, pulling the chest down, sliding your finger up into this space to promote the tongue moving upward into the palate. Nasal breathing doesn't change the palate unless the tongue is up there, but it can support overall well being because we still want them breathing through the mouth. And so, doing lots of munching, maybe some taping around the lips or like lip activities to improve that awareness, because you can get lip closure and the tongue still be sitting low. So, it won't change the palate, but it will help for air filtration and calming baby. Airflow is there. They don't have that connection to the palate. But you can teach other things, humming. You can rock with baby with their mouth closed, and we don't get that air hitting the palate and exciting that nerve. So while it's not optimal, it's better, right? Then open mouth, air flowing in, babies in fight or flight, the palate is high, like all the things. We can do things that are better in order to that, so that when baby is old enough, when they are 4 and you can sit down and talk to them about these things, they're it's not this odd thing that they've never heard or seen before. They're used to you talking to them about it. They're used to you building good, positive experiences with their mouth. They're more open to that. Or you wait until 6 and they're, in orthodontic work and that, while they understand more, or 8 years old and they're getting braces and a palate expander, yes, they understand more, but it's still oral trauma. And so we're still having to work through that. So you can be building these positive experiences, supporting nasal breathing, getting to the muscles as much as you can in prep for any sort of thing that may have to come later. And kids understand way earlier than I think people give them credit for. I start talking to my kids about closing their mouth, breathe through your nose, make it into a song when they're 15 months. I mean, in that 12 months, what I'm doing there, really at 8 months, who am I kidding? Like when they're really young, I'm talking to them. We close our lips, we breathe through our nose. And you can hum out, and then they listen and they absorb that, and then they start to imitate, and then they start to understand, and then they're imitating for a different reason, right? Imitation first happens out of exploration, and then imitation happens out of response, like they know what they're doing for something else. Okay, I hope that helps. I will see you guys Thursday and we'll talk about some more things. Bye.